Good morning. Let's start with approach and initial management of Adnexal Trauma. So we have a 72-year-old gentleman who was brought to casualty, who was unconscious, disoriented, and tachycardiac, hypotensive, and breathing shallowly. So there is clear indicators of systemic compromise. Then how should we proceed? So first we have to stabilize the patient, prioritize the life-threatening issues. We should check for basic principles of ATLS like airway, breathing, circulation, and always keep in mind about head and neck injuries unless ruled out. So my first commandment in orbital trauma is check ABC and then take a step back. We have another 38-year-old gentleman who was hemodynamically stable, but you can see there is extensive lacerations and edema involving the right upper and lower lids. So in this case, we should suspect globe rupture until proven otherwise, and perform a quick examination before taking a detailed history. Inspect eyes without placing pressure on the globe. If the globe is obviously open, do not check IOP, extraocular movements, and do not dilate the traumatized eye. And place a shield, avoid pad or bandage, and use non-preserved antibiotics like moxifloxacin. When the life and globe is secure, then we have to take a focus history, systemic examination, and ophthalmic examination, and always keep in mind about the medico-legal aspect also. Take a history regarding the incidents, date and time of injury, mechanism of injury, then ocular symptoms like change in vision after the trauma occurred, associated features like symptoms, pain, diplopia, photophobia. Then take a history regarding the treatment taken for this injury, status of tetanus immunization, and inquire about foreign bodies and injuries from animals. And my fourth commandment is take a complete and compassionate history, because only a careful listener hears the truth. And never ignore the past. We have to take a detailed past ocular history. And be systematic. Examine the patient, not just the eyes. Take a systemic examination also. An ophthalmic examination should include recording the vision with pinhole, anterior and posterior segment examination, status of the optic nerve. Then always take a photographic record also. These are the 6 management categories that we will be discussing one by one. We should suspect globe rupture if the injury is from a high velocity sharp object, when the visual acuity is poor, globe is soft with 360-degree subconjunctival hemorrhage. Anterior segment features like positive Seidl's test with a shallow AC, high FEMA, displaced pupil. Posterior segment features like uveal or vitreous prolapse, vitreous hemorrhage, a loss of red reflex. If there is globe rupture, protect the eye with a rigid shield. Start on IV antibiotics, analgesics, and tetanus toxoid. Take appropriate imaging and start with the primary repair of the globe. And we have to give intravitreal antibiotics if contaminated, and we can plan for a secondary reconstruction if needed on a later date. And we will do primary globe removal only if it is a irreparable globe with no potential for vision, and to prevent sympathetic ophthalmia. In such a situation, make sure that all the documents are proper. Take a second opinion from another ophthalmologist to make patient as well as ourselves safe, and take an informed consent regarding the nil visual prognosis. When there is a tight globe with a diminution of vision and restriction of eye movement, think about orbital compartment syndrome, that is due to the raised intraorbital pressure that can compromise the vascular perfusion of the optic nerve and retina. Here, don't hesitate. We have to perform an immediate lateral canthotomy and inferior cantholysis within minutes as a bedside procedure under local anesthesia, and start on IV steroids and IOP lowering agents. Suspect foreign body from the pattern of wound, and we have to send for imaging. Never do MRI before confirming non-metallic foreign body. We have to stabilize the globe, start on IV antibiotics, tetanus prophylaxis, and surgical removal is needed if it is organic, large, infected foreign body compromising vision. Otherwise, harmless foreign bodies can be observed. Optic nerve trauma can be avulsion, traumatic optic neuropathy, a compressive optic neuropathy. we have to do imaging here, and we can give IV steroids in select cases and decompress if there is orbital hematoma or canal fracture. And always palpate the rim, look for eye movements and infraorbital anesthesia. In case of children, they can present without any features of external features of trauma, and it can be a white-head blowout fracture which need immediate intervention. In case of lid trauma, we have to clean the wound gently, avoid further tissue damage, check for levator, medial canthal injury, look for canalicular injury, and repair it under microscope. So my 10th commandment is restore form, function with patience and precision. So my take-home message is trauma care demands discipline. Be systematic, follow protocol, communicate clearly, maintain proper documentation, obtain right imaging, and work with a multidisciplinary team, because in trauma every second counts, and convenience has no place in trauma care. Thank you.
Thank you, Dr. Aparna.